A very good morning, everyone, and greetings on the occasion of Buddha Purnima. So, my talk today is titled as Systemic Inflammation in Decompensated Cirrhosis, where I've tried to compile both old and new concepts. So, the outline of my talk will be I'll cover some basic aspects of cirrhosis and systemic inflammation, then clinical evidences of systemic inflammation in acute decompensation, pathogenesis of systemic inflammation, then we'll talk about gut bacterial translocation, PAMPs, and systemic inflammation, then what are the consequences of systemic inflammation, immune paresis, circulatory dysfunction, and organ failure, and then finally what treatment strategies do we have to target systemic inflammation, and finally some of the ILBS studies which have been ongoing. So if we talk of the clinical course of cirrhosis, starting from a long-standing pre-cirrhotic disease, there are two major periods: compensated, which is asymptomatic, and decompensated, which is usually associated with one or the other complications, like the presence of ascites, gastrointestinal hemorrhage, hepatic encephalopathy, infections, and these all require hospitalization. Now, this transition from a compensated to a decompensated stage involves an event of acute decompensation, and recently a syndrome called as acute on chronic liver failure, or ACLF syndrome, is identified, which is characterized by a single or a multiple organ system failure, is associated with a very high short-term mortality, and it always occurs in the setting of an acute decompensation event. Now, this ACLF can develop either from a compensated or a decompensated liver and involves several precipitating events. Now, the most influential hypothesis to explain disease progression in liver cirrhosis is the peripheral arterial vasodilation hypothesis, which works on the principle of a progressive splanchnic arterial vasodilation. So initially, this splanchnic arterial vasodilation is compensated by an increase in the heart rate and cardiac output, which maintains a normal effective arterial volume and of course the arterial pressure. So during this phase, the activity of the RAS systems, the sympathetic nervous system, the ADH hormone from the kidney, the renal function, they are all within the normal limits. But as this splanchnic vasodilation progresses, the cardiac output no longer increases, and so there develops an effective arterial hypovolemia, which leads to a compensatory increase in these systems, the RAS system, the SNS, ADH, which then leads to the formation of ascites. Then the preceding stages are the delusional hyponatremia, which is due to a severe hypersecretion of the ADH hormone, representing a more advanced circulatory dysfunction. As this further progresses, it is even more marked by an intense renal vasoconstriction, which leads to its reduced perfusion, low GFR, termed as a type 2 hepatorenal syndrome. There are studies which say that this progressive circulatory dysfunction, however, does not completely resonate with cirrhosis progression. So plasma renin activity, plasma aldosterone, norepinephrine concentration, which are considered as the sensitive markers of systemic circulatory dysfunction, they increase from compensated to early ascites to a long-standing ascites. However, they do not increase with further complications. Also, as we just discussed, that the cardiac output also decreases with the progressive renal dysfunction. So certainly there is more underlying. So the new hypothesis states that advanced cirrhosis can be explained as a result of a systemic inflammatory syndrome than just a mere hemodynamic or a circulatory disturbance. So according to this hypothesis, any event of acute decompensation in cirrhosis share a common pathophysiological mechanism, which is called as systemic inflammation. So what is systemic inflammation? We all know that systemic inflammatory response syndrome, better known as SIRS, is an exaggerated defensive response to any kind of stress, maybe infection, maybe trauma, maybe surgery, ischemia, etc. And its purpose is mainly defensive. It acts to localize and then eliminate the insult. So these are the characteristic features of having a SIRS. Any of these two: increased heart rate, temperature, respiratory rate, or increased WBC levels. SIRS with an infection called as sepsis. Sepsis with an organ dysfunction, severe sepsis, and severe sepsis with a hypotension, septic shock. So overall, the systemic inflammation or SIRS involves the release of acute phase reactants from the liver, which we will discuss further, and then they directly mediate many changes systemically. Majorly, on the immunological level, each and every cell of the immune system undergoes changes. When we talk of monocytes and macrophages, they cause increased production of all pro-inflammatory cytokines. The receptors are all elevated. These cells have increased functions of antigen-presenting cells. Neutrophils have increased respiratory burst. They show increased migration due to the expression of increased expression of CD11B and CXCR2. Natural killer cells, they are more cytotoxic. There is increased production of pro-inflammatory cytokines and receptors on these cells as well. Dendritic cells, the conventional APCs, also show increased markers of HLA-DR, AT, 86, all involved in antigen presentation. And T cells certainly show high levels of CD25, TCR, and also increased trafficking. So what clinical evidence do we have for systemic inflammation and decompensation? So in a study which included patients with decompensated cirrhosis with and without ACLF and healthy subjects, they measured about 29 cytokines, inflammatory cytokines, oxidized circulating albumin as a marker of systemic oxidative stress, and plasma renin levels as a marker of systemic circulatory dysfunction. So the study showed that patients with acute decompensation, even without ACLF, they have very high baseline levels of these inflammatory cytokines, oxidized albumin, and the plasma renin levels. And the ACLF, patients with ACLF, they showed even higher levels of these markers. And when they studied the association, they reported that the severity of systemic inflammation markers with that of ACLF was higher than the marker for systemic circulatory dysfunction. So in another recent study, a single center European studies, the patients were classified into 6 prognostic stages: mild hypertension as S0, clinically significant portal hypertension as S1, presence of varices as S2, any history of variceal bleeding S3, then the first non-bleeding decompensation event, mostly ascites, S4, and then any other decompensation event after that, S5. So they measured CRP, IL-6, and all other scores in these 5 classes of patients, and they could easily see that after stage 3, both IL-6 and CRP, they showed a very sharp increase. IL-6 also emerged as an independent predictor of decompensation at 1-year follow-up and also predicted death or transplantation in these patients after 1 year. So systemic inflammation, they concluded, drives major complications of cirrhosis. Then another study, interesting study, European multi-center study called as PREDICT study, which was performed in 48 hospitals, enrolled more than 1,000 patients. They used WBC levels, CRP levels as markers of systemic inflammation, and they followed the patients for 3 months, and they defined or identified 3 different patients with different clinical courses. So the first course of patients were stable decompensated cirrhosis, which have less frequent complications and lower 1-year mortality risk. Now these patients have both lower systemic inflammation markers and lower portal hypertension. The second category of patients were unstable decompensated cirrhosis. So these patients had higher systemic inflammation and also suffered from a severe portal hypertension surrogates, like they had more GI hemorrhage, they received TIPS, or they died due to hypovolemic shock. But these patients did not develop ACLF. The third category was a pre-ACLF group, which developed ACLF within 3 months. They had higher systemic inflammation but lower surrogates of these portal hypertension complications. They had higher mortality and certainly organ failure. So they concluded that acute decompensation is a heterogeneous condition with different clinical courses depending on the pathogenesis mechanisms of either systemic inflammation or portal hypertension. Then there are many other studies which have reported that systemic inflammation is associated strongly with organ dysfunction, like we have kidney dysfunction or chronic renal injury called as hepatorenal syndrome, which is a reduction in GFR in cirrhosis. Cardiovascular system abnormalities, encephalopathy, all have been associated with increased chronic systemic inflammation. The presence of SIRS with or without infection has also been shown to be a major prognostic factor for acute kidney injury, which is one of the severe and fatal complications in patients with HRS. Then development of hepatopulmonary syndrome also shows association with the release of several pro-inflammatory factors in patients with cirrhosis. And recently, even depression and neuroinflammation in patients with cirrhosis has been associated with the episode of systemic inflammation. So now, what is the pathogenesis? So talking just about a healthy liver, so we know that a healthy liver is highly tolerogenic. Even though it is exposed to very low levels of bacterial and food components from the gut, it doesn't react. And from the gut end, the integrity of the gut epithelial barrier, the composition of the gut microbiome, its protective role, and very stringent protective mechanisms in the gut, they minimize the extent of the bacterial products which enter the normal liver. Now, on the liver side, the liver is equipped with the gadgetry to contain the infection. So it has antigen presenting cells. Besides the conventional ones, which are dendritic cells and the Kupffer cells, we have hepatocytes and liver sinusoidal endothelial cells as well, which act as antigen presenting cells in the liver. And how do they maintain tolerogenicity? So under basal conditions, these hepatic APCs, they express low amounts of MHC expression. There is an absence of MHC2 in the hepatocytes and also an expression of inhibitory molecules like the PDL1 by sinusoidal endothelial cells. So due to these factors, these cells support T cell proliferation, but they do not license effector CD8 T cells and also generate tolerized or regulatory T cells. But whenever there is an increased infection or inflammation, there is an expression of additional TLR ligands by the liver cells and upregulation of the antigen presenting molecules, downregulation of the inhibitory molecules, and certainly elevated levels of the co-stimulatory molecules. And all these then lead to activation of and differentiation of effector CD4 and CD8 T cells. So once these cells in the liver are activated, they release cytokines, and the major cytokine is known to be IL-6, which then leads to activation of the acute phase proteins in the liver. We have many such proteins like CRP, ferritin, fibrinogen, serum amyloid protein, just to name a few. And so these cytokines, along with these acute phase protein, then generate a systemic response at all levels, leading to many changes. So what induces systemic inflammation? So we know that we have pathogen-associated molecular patterns, which include LPS, peptidoglycan, lipoic acid, from gram-positive or negative bacteria, which are usually from the intestine. And we have dead cells or DAMs, which again include many molecules like HMGB1, mitochondrial DNA, uric acid, etc. So these bacterial inducers or the endogenous inducers again are defensive, and their purpose is to compensate and promote host resistance, either by reducing bacterial burden or by introducing sterile inflammation, which is done by the DAMs to promote tissue repair. Now if we see the mechanisms, so both increased PAMs and DAMs, they bind to certain pattern recognition receptors or PRRs on the liver cells. Like for LPS, the most characteristic ligand is TLR4, but certainly we have more receptors. And the two pathways which are activated, one is mid-dependent and one is mid-independent. When we say mid-dependent, it usually terminates into NF-kappa B, works through the transcription factor NF-kappa B and produces IL-6 and TNF-alpha. Mid-independent pathway, on the other hand, activates mainly the interleukin regulatory factor 3, IRF3, and which usually results in the production of IFN beta and CXCL10, the other kind of pro-inflammatory cytokines. Now, although the PAMs have been reported to cause acute decompensation and organ failure, we have limited or very less data to show that DAMs lead to acute decompensation, although there are many studies which show that DAMs are involved in the progression of liver injury in alcoholic steatohepatitis, non-alcoholic steatohepatitis, and even drug-induced liver injury. So what data do we have for bacterial infections as inducers of acute decompensation? So the same PREDICT study, they investigated patients with acute decompensation with and without ACLF, and then they studied many precipitants, and among all the precipitants they showed that two of these precipitants, one the presence of proven bacterial infections and other severe alcoholic hepatitis, they both are important or they both have similar role in acute decompensation with ACLF or without ACLF, and they also have, patients also have a similar mortality in both cases. So the number of these precipitants also coincided with the increased markers of systemic inflammation and certainly 3-month mortality. And this is also well established that approximately 2/3 of patients with cirrhosis and extrahepatic organ failure have sepsis. Now, how do we know that PAMs induce systemic inflammation? So we have very less studies in this direction. So a longitudinal study which investigated 5 patients, they measured sequential levels of plasma IL-6 as a marker of systemic inflammation, and they studied them during a follow-up period of 14 weeks after discharge. So they could see very good peaks, the crests and troughs of IL-6, and they hypothesized that they may be interpreted as a secondary to transient bursts of translocation of intestinal PAMs. But as I said, we need more studies in this direction. Then we have preclinical studies saying that PAMs are inducers of acute or chronic liver failure. So in an animal model of full-blown cirrhosis, whether induced by CCL4 or thiazidamide, even if exposed to low-grade endotoxemia, leads to systemic inflammation, organ failure, and recapitulates attributes of ACLF. So we have 2 studies, like one published by Dinesh in Gastro and one published by Dr. Anupam's group, Nidhi, which showed that in the animal models, LPS administration gives rise to high systemic inflammation and ACLF model. So now we know that we have, as the cirrhosis progression takes place, the gut-derived PAMs, or what we call as pathological bacterial translocation, it emerges as a major mechanism for disease progression. And this is also evidence that SBP, the infection of the ascites, is also commonly associated with cirrhosis. So what determines bacterial translocation? from the gut to the liver. So there is physical disruption of the intestinal mucosal barrier, there is overgrowth of the gut bacteria, and then there is suppression of the gut immune defense. So under inflammation, the intestinal barrier, both the epithelial and the gut vascular barrier, is disrupted. We have the presence of SIBO, dysbiosis. They enhance the translocation, they increase the bacterial load of both metabolites and live bacteria to the liver. And an important component of bacterial translocation is gut-associated lymphoid tissue. So this GALT is actually organized within 3 compartments. In the gut, we have an outer epithelial layer, the underlying epithelial layer, lymphocytes in the underlying epithelial layer, and then organized patches of the lymphocytes. These organized lymphoid follicles are called as Pierce patches and mesenteric lymph nodes. So what happens is the commensals or the pathogens, they are captured by the M cells. Why by the M cells? Because these cells do not have a layer of mucus, because there is no goblet cells. So mucus is mostly produced by the goblet cells. So these M cells capture the bacteria and then they pass them to dendritic cells, which then traffic to Pierce patches or MLNs and trigger the B cell or the T cell responses. So here afferent and efferent lymphatics, they play crucial roles in transporting the lymphatics in and out of the MLNs. And then from the MLNs, in the MLNs, the bacteria are killed and the activated lymphocytes then are transported back to the blood through the thoracic duct. So besides these mechanisms, we have antimicrobial peptides, which also limit the exposure of the bacteria, and bile acids also reduce bacterial growth and endotoxemia. So talking of mesenteric lymph nodes, they are at the center of the bacterial translocation. Actually, in healthy conditions, commensal bacteria, all commensal bacteria, they are transported to MLNs by DCs. They induce a certain amount of local response, but are killed within the MLNs without inducing any systemic immunity. So we can say that MLNs actually confine the live commensals in the gut itself, avoiding the systemic immune response. So there are many elegant studies which have reported that if MLNs are removed, bacteria-laden DCs, they carry these commensal bacteria to the spleen, ultimately triggering the systemic inflammation. So pathological bacterial translocation is defined by an increased load of bacteria or live bacteria in the MLNs. Now in cirrhosis, both the lymphatic route via the MLNs and thoracic duct and the portal venous passage has been reported to spread bacteria and bacterial spread. But again, we do not have very systematic studies comparing these two routes, hematogenous versus the lymphogenous spread. So mostly we have experimental studies of MLNs in cirrhosis. So cirrhotic rats with ascites only show positive or high bacterial load in the MLNs. Studies have also shown translocation of GFP labeled E. coli both to MLN and ascites. And in patients, pathological bacterial translocation is significantly increased only in child C patients. So the only independent predictor of pathological bacterial translocation is the child pug class. However, we do not have many clinical studies of bacterial translocation in cirrhosis because we do not have reliable, robust markers to detect its presence in the blood. So some of the molecules which have been used, like bacterial DNA, soluble CD14 or LPS binding protein, PCT, have been used in the blood and as well as the ascites. And another important thing is that animals, either animal studies or patient studies with ascites, they have shown that along with increased pathological bacterial translocation, these models also have increased local production of TNF alpha in the MLNs. So we can say that the pathophysiological road for the development of spontaneous infections and systemic inflammation, MLNs are an important component. Now, what are the consequences of systemic inflammation? So we just talked about how the whole innate and the adaptive immune system goes haywire in systemic inflammation. There's an excessive production of these cytokines which mark a high-grade systemic inflammation. But when there is very high systemic inflammation, there is a compensatory anti-inflammatory response as well. We have secretion of IL-10, and this secretion of IL-10 then leads to the pathogenesis called as immune cell paralysis. It modulates NF-kappa B activity, it decreases TNF, IL-6, it induces high levels of immune inhibitory receptors. There is a recent ILBS study by Dr. Nirupma's group in HAPCOM, which says that how these markers are decreased in patients with ACLF. We have neutrophils showing high level of CXCR1 and 2, but they have reduced functional or phagocytic abilities. Then circulatory dysfunction is also highly affected by systemic inflammation. So we all know about the nitric oxide paradox in cirrhosis. So we know that on one hand, nitric oxide is decreased in the liver. There is a presence of endothelial dysfunction, and this contributes to increased intrahepatic vascular resistance, leading to portal hypertension. But on the other hand, we have increased vasodilatory molecules or nitric oxide in the splanchnic circulation. And it is well reported that eNOS activity is actually decreased in both the liver and splanchnic circulation in cirrhosis. But then there are other mechanisms in splanchnic circulations which increase nitric oxide, like TNF-alpha is a well-known mediator of nitric oxide released via iNOS. Then NF-kappa B, NF-alpha, LPS, they all mediate a direct increase in nitric oxide synthesis by increasing its cofactor tetrahydroterine. And interestingly, even bacterial translocation is known to increase tetrahydroterine levels in the mesenteric lymph nodes as well as in the system, which correlates very well with TNF-alpha levels. Then systemic inflammation causes organ failure. So one, we just studied immune paresis. Second, endothelial activation or endothelial injury is one mechanism which might connect systemic inflammation and organ failure, but we definitely need more studies in this. So we all know that sepsis, pro-inflammatory cytokines, they all target the outer protective layer of the endothelium, which is glycocalyx, and disruption of this glycocalyx then exposes many endothelial cell adhesion molecules which further trigger inflammation, addition of WBCs and also platelets. And this loss of barrier function in the endothelium causes decreases tissue oxygenation, leading to organ failure. So we have studies both from in and outside of ILBS, where we have shown that soluble markers of endothelial injury like ICAM1 and neutrophil activation have been linked to organ failure and poor clinical outcome. Another mechanism which links systemic organ failure, systemic inflammation with organ failure is cellular bioenergetics. So it has been recently proposed that there are significant metabolic alterations which are associated with release of pro-inflammatory cytokines. The activated immune cells actually become more anabolic. So most of the nutrients are now disproportioned or taken up by these cells, whereas the other cells of the peripheral organs, they do not get, or they limits their nutrient consumption, which leads to a decreased mitochondrial consumption and ATP production in these organs. I think Dr. Anupam will have more data and more insight on this. So finally, the cost of decreasing mitochondrial energy production may be another link of systemic inflammation with organ dysfunction. So to sum up, we can say that the intensity of inflammation certainly increases with complications of cirrhosis, starting from low-grade inflammation, where we have all factors increased and no immune paresis. But with high-grade systemic inflammation, we have immune paresis with less of many of these molecules, less of neutrophil functioning, less of monocyte macrophage functioning, which finally drives the organ failure. So what treatment strategies do we have to what treatment strategies do we have to combat systemic inflammation? We know albumin treatment has been shown to reduce acute decompensation, and it has been clearly shown that albumin not only improves circulatory dysfunction, but it also improves the levels of CRP and other cytokines. Then it also modulates response to TLRs and PAMs. Then treatments on this line like anti-TNF treatments, microbiome, FMT, antibiotics, probiotics, prebiotics. We have many such studies, and we certainly need more data on this. But yes, all patients do not respond to treatment, again, because we are just talking of precipitating factors, and different patients will have predisposing factors as well. So with regard to ILBS studies, so our group has been investigating these gut lymphatic vessels since last few years, and we have been investigating this channel from the duodenum to the mesentery to the mesenteric lymph node in various aspects of both ascites formation and systemic circulation. And one interesting point which I would like to share is that just like the liver sinusoidal endothelial cells, these lymphatic endothelial cells are also immune tolerant in homeostasis. But in inflammation, they do react with immune cells and generate adaptive immune response in the MLNs. So in Pinky's thesis, what we are doing is we are finding out the link between the gut lymphatic vessel dysfunction and impaired immune responses in the gut and systemic inflammation in liver cirrhosis. So I'll not discuss most of her data.
I think we can do it another time.
So just one slide.
Yeah, because this is an area which you have expertise. So we should have lymphatics as the only thing which you have done. Maybe share one slide or slow.
Yeah. So just one slide I'll share what study we have just communicated, where we have taken D2 biopsies from patients with liver cirrhosis and controls, and we have done a staining of the podoplanin, which is a well-known marker of lymphatic endothelial cells. And the scores clearly show that patients with decompensated cirrhosis have very high levels of podoplanin and dilated lymphatic channels as compared to patients with compensated cirrhosis. And this score very significantly correlates with systemic inflammatory markers like IL-6 and also intraepithelial lymphocytes. And in this small study, we have also shown that how this predicts a score of greater than 6.5 predicts 3-month mortality in patients with cirrhosis. Then Pinky is also doing some studies preclinically where she is examining animals with and without bacterial translocation. She is isolating mesentery and MLNs and then isolating LYCs, and then she is also studying bacterial translocation. And as you can see that the bacterial load is clearly increased in the MLNs with positive or decompensated cirrhosis with ascites, and also in all the other organs. Then she has characterized molecularly this LYCs in the MLNs of cirrhosis, and she is going to present this data in the EASL this year. So to conclude, systemic inflammation might be postulated as a key mechanism in the development of episodes of acute decompensation of cirrhosis leading to multiple organ dysfunction, and abnormal translocation of bacteria from the gut might be a pathogenesis factor. Bacterial translocation also exacerbate hemodynamic derangements leading to decompensation, and a persistent high-grade inflammation leads to immune suppression, causing an impaired response to pathogens at different levels, sepsis, organ dysfunction, and failure. And certainly we need robust early biomarker, early mechanisms of gut bacterial translocation even before development of sepsis, if we can predict sepsis, and novel strategies targeting bacterial translocation and inflammation are certainly required. And here I end, and I thank all the people who have been involved and guiding us in this work. And we have currently 2 projects running on lymphatic channels and lymphatic endothelials from DST and SARP. Thank you.